Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. I'd like to welcome Dr. Ashok Bhattacharya and Lonnie Hirsch. Thanks for joining us today, Ashok and Lonnie.
Thanks very much for inviting us.
Absolutely. So I usually start by saying how we met. So Ashok, looking back, you were one of my very first connections on LinkedIn. I reached out to you a year ago, April 12th, and I think I've only been on a year, April. And I said that we both know Dr. Michael Hirsch and that I appreciated your comments on his posts. And then, Lonnie, I reached out to you last July saying that we shared a number of mutual connections and that I was collaborating with Dr. Todd Otten. And then we Zoomed back on September 25th. So that was like over 7 months ago, which I can't believe. And
And
then we're all connected with Dr. Jonathan Fisher. So I thought I'd use this opportunity to give his book a plug. I just got it this week, and it's a beautiful book. I can't wait to read it. And Lonnie, you and I are even mentioned in here as
oh,
a couple of
really?
his early supporters.
Well,
So
that's nice. I'm jealous that you already have your copy. I keep going to the mailbox and I know it's on its way.
I
So
think
I
it's
have
we're
my
both on
copy.
the.
I'm reading it now.
Oh, are you? Oh, you got yours already too. Oh
Oh,
my goodness!
absolutely. Have to
Wow.
put it away.
And you're even ahead of me. Okay. All right. Well, we'll have to regroup again when we've all read the book.
Right.
We'll have a reunion episode. Okay. So, by way of introduction, Dr. Ashok Bhattacharya is a psychiatrist in Ontario. He's the founder and president of the Empathy Clinic, practicing interpersonal psychotherapy since 1989. Ashok is the author of two books, Cake, A Guide to Reciprocal Empathy, a manual for consolidating marriage relationships, and Deep Fried Nerves, a fictional novel that follows a burnt out psychiatrist through to his recovery. Ashok has lectured internationally on balance and burnout in physicians and mental illness in physicians. And Lonnie Hirsch focuses on healthcare consulting in Portland, Oregon. He leverages the power of focused, directed, and actionable collaboration to help improve healthcare delivery, access, and experience for patients, care providers, payers, and employers. And he founded the Healthcare Reinvention Collaborative with Denise Weissman, which is awesome. Absolutely. And today we're going to be talking about a message of hope for physicians. Ashok will speak to embedded shame in med school and med practice, prevention of burnout, and his favorite topic, the use of empathy in medicine. And Lonnie will speak to what the Healthcare Reinvention Collaborative is all about, and we'll take it from there.
Sounds
So,
great.
yeah. So as we get started, Ashok, what would you most like our audience to know about you?
Well, I think that I'm embarrassingly optimistic. And I think that's been a very, very good quality for me to have over the course of my life, including successes, but more importantly, about how to handle disappointments. And I didn't want to be a doctor. I wanted to be a psychiatrist.
Hmm.
And I was always interested in how people felt. And I had a little bit of a medical illness as a child that got me stuck with girls during recess. So I wasn't able to play soccer with the boys. And I got realizing that girls talk about feelings and thoughts. They're reflective and they talk about empathy. The guys just wanted to punch my shoulder and kick the ball. So that's a stereotype. But I got really interested in how people think and feel and how we have the capacity to share how we think and feel and how receptive people are to sharing that and receiving that from others.
Wow, that's beautiful. I love that story. Thank you.
The only thing I would ask is why would you describe that as embarrassing in terms of your optimism? Because I think it's awesome, and I try to stay optimistic as well. But sometimes it's harder, and you just kind of got to look at that half full glass.
I think it is half full generally. I think that the issue, though, is what we call realistic versus unrealistic optimism. And I think as clinicians, we have to be the bearer of the cross of sometimes of terrible news. And we still can find a way to manufacture hopefulness and optimism in the transmission of that news to our patients.
Yeah, that's very important for sure. Yeah. And Alani, as we get started, what would you most like our audience to know about you?
Well, I'm old. And I'll only mean by that I'm somebody who's had a lot of experiences on my journey on the planet, and came from an environment for many years when I was working with doctors and other providers of care in terms of marketing their services and their practices, and hospitals and health systems, and owned an agency, and that was all great. And I felt, we did a lot of good work. But as I got older, I got more focused on what patients and providers of care were experiencing in that relationship, or the barriers to those relationships. And those were areas that, as a marketing agency, you don't generally get invited into those conversations and opportunities to have some kind of a positive impact on that. So after I sold my agency a number of years ago, I started doing more consulting work, and formed a small consulting group. Most of my conversations being around those issues of patient experience and the engagement of patients in the process, and the challenges that care providers are constantly faced with. And so that also led me to the work that Denise Weissman is doing, and that I started joining her on last year, that has evolved into what we're calling the Healthcare Reinvention Collaborative, with I'll be happy to talk more about as we go along today.
Okay, yeah, that's terrific. Yeah, I'm very interested in it, and I've attended all the Zooms, and they've been phenomenal.
Great. We know
So,
we love having you there.
yeah, thank you. So Ashok, did you want to start by talking about embedded shame in medical school and medical practice?
Yeah, I want this to be palatable to the audience. I think that shame is a difficult emotion, and guilt is an emotion that takes responsibility for something that you've done wrong. And shame is more because you feel that you're a bad person because of what you've done wrong. So it involves the whole person. And I think when people apply to medical school, certainly this is my case, in the case of many people I know, you're often a type A person who is a bit perfectionistic, who wants to please people, who wants to help people, and all those wonderful attributes. That's great. But does that set you up to handle disappointment and failure? Does that set you up to be in medical school and now instead of getting an A, you're worrying about passing? Does that set you up that when you start your practice, that things become difficult? You have difficulties with clients to deal with sometimes. Sometimes your family life is getting upside down, and you have to hide the feeling that maybe you're struggling. You have to hide the feeling that you're not feeling optimistic about the outcome of this. And so you hide, and shame tends to hide. And when shame hides, it can do damage to ourselves socially, emotionally, spiritually, physically. We know this. And I'm on a mission, and I think it's a little bit difficult, but to expose some of the shame without upsetting people. Because if we're in medical school or starting out our practice or in the middle of our practice and we're starting to hide, that can set up a terrible precedent of not looking after ourselves and pretending to at the same time. And that's dangerous, and that can lead all the way to someone not thinking life is much worth living as well. That's another issue. So I think shame is important to describe and make it okay to talk about. Because when doctors talk to each other, especially if they talk to each other about feeling helpless and hopeless and they're struggling, the mere fact of just having that conversation with each other means that we're not alone. We now have companionship with that feeling. So we're not alone with that. And that can embolden and create resilience in that feeling of helplessness, which begins to change the basic feeling. So that's where I'm coming from with this. And instead of just working with one-on-one with doctors in my office, that's why I'm trying to get that message out in a larger social platform. And guess what? It's beginning to hook, and people are talking about that too. So thanks for asking that question.
Well, I love that. And I have to add that I love LinkedIn, where doctors are talking about these things and their own stories and experiences with shame. And also, Kevin MD, all the articles on there. I recorded a podcast this morning with him and Dr. Sarah Witry. And even,
Right.
these episodes here, right? Stand Up for Doctors, where I have doctors on talking about these things. So I've said multiple times, every time a doctor shares their story, another doctor feels less alone. So it's critical and
Exactly
important.
right. Exactly
So
the point. Thank you for saying
yeah.
that.
And just as somebody who has worked with a lot of doctors over my career and known a number of them personally and socially as well, I think shame is even more difficult for doctors because and I'd be interested in Ashok's feedback on this. They're brought up in an environment, and their medical training and their peer pressure is all around avoiding mistakes and the high risk involved in mistakes when they're made in medicine. And so the potential for shame when there's any kind of an adverse outcome is probably a daily potential, or certainly a frequent one, I would think. And there isn't a safe space generally that I would think a doctor would feel okay about talking about it, even with a spouse or family. It's a shame is a very private emotion. That's the point you were making about it stays hidden because it's shame. It's shameful. And so it's a trap in that respect. So I can certainly see how important that is when you're addressing it in the environment of medical care.
Yeah, just to respond to what you said that is so valuable is that often people who, let's talk about getting into med school, they've been told their whole life they're brilliant, they're excellent, they're a role model to other people. And that sets up a very high bar that once they start having real experiences in medicine, disappointments and failures, losing a patient, not being able to cure somebody, etc., they may not have the apparatus that they built up over the years to manage this concept good enough.
Right.
And in medicine, when we get audited by our colleges, they're only finding out if we're good enough. They don't need us to be excellent. They need us to be good enough. But your whole life you've been told you're excellent, and good enough just isn't good enough. So we hide that. Thanks, Lonnie, for that comment.
Hmm. So Lonnie, would you like to introduce us to the Healthcare Reinvention Collaborative?
Sure, and I appreciate you inviting me on to talk about it. So, as I write a lot on LinkedIn, and I have a lot of conversations as well with people around the challenge in what we call a healthcare system today, and um, what we what we struggle with, so many people in there's a common understanding and even an acceptance that it's a difficult, problematic environment. Whether people admit it openly or they acknowledge it privately, there's not a lot of really controversy around that issue. But the issue of whether or not the way to address it is by fine-tuning or improving the existing system model, or trying to come up with something that is substantially different and hopefully better, is an ongoing conversation. And I guess, depending on your point of view, could be considered somewhat controversial. Well, there is a process organically, and I'm not a biologist, and I wasn't I wasn't going to major in medicine. I never, took that path, but there is an organic process in the world and in the universe of evolution and decline and emergence of the new after the old decays. And that happens in all kinds of work and social and business environments as well. And a number of us who are working on this collaborative were exposed not that long ago to something called the two-loop model, which is a really interesting way of showing how systems grow, peak, decline, and then eventually completely collapse, to be replaced by something. It's always replaced by something. The question is, can you strategically organize the replacement environment so that it is more and better than what came before it? So when you tell people who are working in the current model that the current model is decaying and in fact is inevitably going to have to continue to decline, that's a harsh reality to have conversations about, because there's a lot of understandable protection of the, you can't just abandon it, right? You can't abandon what's going on. And that is, in fact, very true. You can't abandon people. We have people experiencing the current system, both on the giving and the receiving end of it. So the question is, first of all, can you acknowledge that the current system isn't going to improve? And if you can acknowledge that, can you be willing to collaborate on developing what comes next, and in the process, make the transition between what's declining and what will be emerging as painless as possible, with as few casualties as possible. So if you think of it in a way, and I know it's going to sound maybe a little medically grim, but if you think about it in terms of the current system going through a compassionate hospice process, in the process of that decline and planning ahead for the emergence of the new system, then you might be able to see that light at the end of the tunnel, instead of just assuming that everything's just going to get worse and we have no power to affect it. And we're, I've written about learned helplessness. We all buy into that at some point, because as individuals, we usually feel pretty helpless. So the idea of the Healthcare Reinvention Collaborative is to connect people who, number one, are of a like mind that the existing system isn't going to just magically improve, and they're not willing to just sit and watch it decline. They want to do something about it. And there are a lot of people already innovating solutions toward that newer model, but they often don't know who else is doing something similar, or where there could be an opportunity to actually have a group on the West Coast that's working on problem one, and a group on the East Coast who's working on a similar problem or the same problem. They don't even know about each other's work. The opportunities to collaborate, therefore, aren't capitalized on. And if you can connect, highlight, amplify the work that's being done, and foster an environment of positive collaboration, you might be able to accelerate the change toward a positive new system. And that's really what the collaborative is about, is connecting, highlighting, amplifying, and supporting those innovative efforts, and building enough size that the people who are not willing to accept the status quo as inevitable get taken seriously.
Yeah, well, thank you so much for that, Lonnie. And I feel like you guys are helping to become, right, a network of networks, and to see on these calls the change leaders around the country. So I just love that you're spearheading that. So thank you very much. It's very exciting. And then also seeing how it can be replicated not only in different areas of our country, but other countries, whether it's Canada, Australia, the UK, right? Because we're all experiencing, I've had doctors from Australia, New Zealand, and the UK, and right
Exactly.
on here, and we're all experiencing the same types of struggles and issues. So we want to find what works so it could be replicated. So yeah, thank you for that work. And Ashok, another thing we were going to talk about is prevention of burnout. So as we talk about when he says our system is getting towards a slow hospice, we just hear that more and more physicians, over 50%, maybe it's 60 or more, are experiencing, symptoms of burnout, et cetera.
Well, I'm going to jump in and just borrow a phrase that Lonnie mentioned called learned helplessness. And Marty Seligman talked about this in his book on optimism. And it's a persistent belief that a situation is inescapable. And I always think, and I'm going to just hit this hard, empathy is the problem in two base conditions we see in psychiatry all the time. One is PTSD, and the other one is burnout. And I define burnout in many, many ways. But as I get older, I think it's a lack of self-empathy. Because if you can't take perspective on yourself and see where you're going and see what's happening to you, and then starting to feel numb and blunted, then your self-empathy is not going to find a way out. And if you accept that and you can't see out of that, you will become helpless in your own helplessness. And I think that empathy, and I'm just going to bash this because this is what I do. I think empathy can reach right through the entire healthcare system. And I remember when I was working as a resident in these psychiatric units, in my past, I used to be a nursing orderly in a psychiatric hospital. And I always used to go up to the orderlies and ask them, what was this patient like last night? What was going on there? And they couldn't believe I was asking their opinion. I was giving them value on the assessment because we're all on the same team. And let's never forget that organizations are ultimately made up of people. We're just people. And people have been endowed with an incredible capacity for empathy. And if you speak to the person sweeping the floor in a hospital and ask them, do you think that the CEO of this hospital knows what you do or how hard you work or what you have to go through to get to do that? Would it make a difference if they met with you and said, how can I make your work better? Or how are you enjoying working here? If they're going to do a better job of sweeping that floor. And I think you don't have to have a lot of empathy. A little goes a long way. When people feel they're being empathized with, they feel way less burnout. And that teaches them to remind themselves of their self-empathy, which was reflecting on where am I at right now. And if you lose your self-empathy, you can quickly get burnout. But if you bring it back, you can prevent it. And that can be across the table and across the pyramid in a hierarchical system. I'll leave it there.
Just one thing I want to comment on is some doctors don't like the term burnout, like they think we should be saying mortal injury, but I feel like the two are different, and I feel like I had experienced both, while I was working and we switched to the EMR. So I didn't know if you wanted to speak it up, because sometimes if you say burnout or it's self-empathy, that some doctors would say places the onus on them when they feel the system is the problem. And then
Well, I
Lonnie,
think
I'll
that's
let you speak to it after Asha.
Yeah, well, that's a huge issue. And we noticed this in the Great Wars when some soldiers felt they didn't want to go back to the battlefield and it was their problem rather than the system that they're in. We have to see burnout as a systemic issue that can affect the individuals. And if someone doesn't want to admit to burnout, I mean, no offense, we all ultimately burn out and die, right? Burnout is wear and tear. And if you don't see it as that and don't look after your car and change the oil, it's going to burn out too. So when we all admit that we're all slowly burning out, let's help each other with that. Let's create a team sensibility around that. It's a lot easier to admit burnout. When I go to the burnout healthcare seminar regularly, and the rooms, who's ever been burnt out, 90% of the hands go up, right? Because med school burns you out at the very least. So I think the idea of, are you getting burnt out? I think it's much easier to talk about what you're going to do about the potential for burnout than do you have it or not. And I think that's the emphasis that will create a better, safer, and vulnerable dialogue around that conversation.
I guess my thought on it is that it's not just doctors, but anybody who's providing healthcare. is in an environment where they're interacting with people who are absorbed with their own problem. That's why they're there. Their own fear, their own anxiety, their own physical and emotional pain. And so they don't tend to naturally be focusing on the person who's giving the care because they're in their own head and their own body, and they're preoccupied with that. So it's easy to not even make that human connection. And on the other side, the doctor or provider of care, particularly though with doctors, I think it's more of an issue, are trained to not reveal themselves as human beings and to not reveal their vulnerable side. And it's to put up that protective wall so that they don't absorb so much of the pain that they burn out that much sooner. So you've got this artificial barrier in the middle on, from both sides. And with the care providers, COVID was a really enlightening moment for a lot of reasons, but one reason was it was the first time I had noticed general population experiencing empathy for care providers on a profound, large level, because it was so evident and it was so dramatic and so important. And yet that moment passed. And the people go on with their lives unless they were particularly badly affected by the pandemic. But the PTSD, and I'm not speaking to Ashok's expertise, but that experience remains with so many of the doctors and providers of care. So if there is an environment where there's an opportunity for individuals to pull down that barrier a little bit and reveal themselves to each other, then you can start to encourage more empathy because it will naturally flow. Once you start noticing what the other person is going through, unless you're completely closed off, you're going to feel something. So I think the work that Ashok that you're doing is so important for that reason.
I always say that, person first, doctor second. So if I meet someone, I'm a person. And my personhood is not a shameful thing. The fact I have a life and I'm a human being. If you go in there as physician first and somewhere in the back room is your humanity, you're going to get burnt out, and the people around you are going to be concerned about you. But I think, Lonnie, you also made a very important point. Burnout is not a doctor thing; it's a human thing, and that we all have to be mindful of it in order to work with it and help each other with it.
And when you mentioned, Lonnie, finding empathy for each other and how the pandemic, for a while everyone was so grateful to doctors and they were heroes. That kind of reminded me of, right after 9/11. So I don't know if Ashok, if it was even like that in Canada, but even at a stoplight, like you were letting other people go, there was that, and it might have lasted, I don't remember, like a week or something, right? Where every other person was a human to you. And did that extend into Canada? Because Lonnie, did you find that where you lived as well? I mean, because I'm here in Connecticut.
Absolutely.
We actually, we were a train ride away from New York
right.
City, and everybody knew somebody that died, but
yeah, absolutely. We felt that in Canada, and a lot of Canadians went to help out. And I remember when my kids were asking me about it, what's happening here. It was a family issue as well. I think we take our safety for granted until we're not safe. And if we're not safe, it's natural for humans to huddle together. And you can put people on an airplane and then put them on a desert island where they absolutely need each other for their survival, and the relationship changes. And who you are on the plane and who you are on the desert island, very different. And I think that's what that experience does. And trauma often causes people to bond quite closely.
Yeah, right. That's a good point. Yeah. So Lonnie, I think you might have had something to speak to how doctors and patients can support each other.
Yeah, that's I mean, it was kind of my previous comment was in respect to how you can create an environment for that. Now, how you support each other when you're listening to each other, really hearing each other, the ways that you can support each other become more evident. So you don't, it's good if you have a certain, set of tactics or ideas in anticipating how you might support each other. But the dialogue, the openness of the dialogue reveals that people will tell you how they feel they need to be supported. Mm-hmm. And when you have the willingness and the openness to hear it, then it becomes a question of, well, can I do that? Is there a way that I can support you? If the environment in which those interactions take place doesn't allow for that, then it doesn't really matter, because all the ideas or all the activities or all the tactics aren't going to have a place to emerge and thrive unless that relationship exists. So, when you go in for well, if it's an emergent situation, it is an emergency and people are reacting to that. But when you are going into a doctor's office for an appointment that maybe isn't technically classified as an emergency, but someone is feeling emotion and anxiety, and yet the doctor is feeling pressure as well, because they're on a schedule and they have 3 other patients waiting for them in the other rooms, and everybody's in their head, right? So it's hard to listen to each other when your primary dialogue is between you and you, mm-hmm. instead of you and the other person across from you. So I guess it's a long way of saying that the way that you support each other, again, is having an opportunity and a willingness to be open to and hear each other. And then the ways that support will manifest itself will become clear most of the time.
Speaking to Ashok and empathy, right? It all goes back to having a little bit of empathy for each other, right? Doctors having empathy for each other, doctors having empathy for patients, patients having empathy for doctors. It all, winds down to that. So,
full circle.
Yeah. So, Ashok, do you have any top tips for your colleagues that you'd like to leave us with?
Yeah, I think there's a few things to say. One is think about yourself. And I always think, and I just talk about being a doctor, first of all. If you don't have room for a hobby, you're going to be in trouble. I always say that. Make time for family and friends, but also check in with other doctors. I belong to a doctor support group, and we speak on a monthly basis. We meet for an hour and a half. We share cases, we chat, we share our disappointments, our upsets. Sometimes we laugh, sometimes we cry. And I find it's really healthy to have a connection with people where you don't have to pretend to be okay if you're not. And if you are, you can help somebody else who's not so okay.
Yeah, wow, that's beautiful. I love that. Are they all psychiatrists that meet together?
They are not. No, some of them are social workers, psychologists, psychiatrists,
okay.
doctors. And I think this is good to mix it up with the group because we're all on the same team, right?
And it helps break down those silos for sure.
Yes, absolutely.
Yeah, great. So Lonnie, how can our listeners get in touch with you, and how can they learn more about the Healthcare Reinvention Collaborative?
Well, thank you for asking. Certainly, you can find out more information on the website, which is healthcarereinvention.com. And that also has a place for you to sign up to receive updates from us and to register for our events. We're putting on events every month on LinkedIn, group what we think of as a gathering. And there might be anywhere from 50 to 100 people who attend our meetings. Our next one is May 21st, by the way. And we'll be talking a lot about the whole concept of the collaborative at that meeting. As far as other ways to get in touch, it's pretty easy for me. It's Lonnie at healthcarereinvention.com, LONNIE. And it's building rapidly. So we're excited, and we hope more people join and attend some of these events.
And would our friends over the border in Canada be welcome to attend?
Everybody's welcome. And by the way, it's not just across the border. We do have people attending those meetings from other areas of the world, because we're all challenged with the same problems in one way or another.
Okay, fantastic. And Ashok, how can our listeners get in touch with you?
Well, once you get the name right,
Yeah, sorry.
I mean, once you get the spelling right, I'm on LinkedIn. I post a lot on there, and that's an easy place to grab me. And my website is theempathyclinic.com, which is even easier to grab. And all my handles are on that particular site as well.
Okay, all right. Well, that is fantastic. So thank you both for being my guests. I knew it would be a fabulous conversation, and it was. And now I'm glad that you guys know each other.
And I want to thank you, Kim, because you're doing so much to connect people who are focused on the challenges that doctors face, and that just in general anybody involved with healthcare at one point or another, that's everybody, has to deal with. So we appreciate you making these connections and
We
supporting.
absolutely do. That's true.
Well, thank you very much. And it seems like whoever I've been pairing up, it's just been a beautiful, relationship. But the funny thing is, if you guys recall, the reason I first paired you up was I was trying to book times for Mondays, and neither one of you were available on a Monday.
Right.
So I'm like, that's perfect. I found two guys. So that's actually how I paired you up, right? Because you were both
Well,
available.
it's worked out, serendipitously, and I enjoyed meeting you, Ashok.
Thank you so much, Lonnie. Great to meet you.
Okay, excellent. So, in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.